IgA nephropathy. So again, IgA mediated disease, and it is the local brother of systemic IgA nephroid vasculitis, but mechanism is not same. The both the cases you have IgA deposition, dominant IgA deposition 2 plus and beyond, and is more common in the Japan, Korea, Taiwan, and on that belt. It is syn pharyngitic or syn gastroenteritic, seen in a small subset of cases. In some of the cases, as I mentioned earlier, it's quite high, 5 to 30%. So they are more common, a little bit grown-up child. Adolescence is more common. And what is the mechanism like? The galactose deficient IgA it incites the immune response in the mucosa, and then produce antibody, and incited by usually microbial agents. The immune antigens, immune complex, deposits in the mesenterium, glomerular tubulointerstitial inflammation, and followed by the fibrosis, sclerosis, the sequelae like, and presentation is gross hematuria more often, and these children do have gut associated lymphatic tissue activity, and nasopharyngeal nasopharyngeal associated lymphatic tissue overactivity. So apart from that gross hematuria, they may have microscopic hematuria, they may have acute nephrotic syndrome, nephrotic presentation, hypertension, azotemia, etc. They may have nephrotic presentation in worst possible cases, and RPGN like presentation is also possible. And so renal impairment can be in the form of your AKI, you can have CKD, even ESRD is also possible. So how to diagnose these things? The Oxford classification, the MAST3, mesenterial endocapillary and segmental sclerosis, T for the tubular interstitial fibrosis atrophy, and C for the crescent, cellular, fibrocellular, and fibrous. So as you understand, your Oxford MAST classification is quite little bit advanced disease in some of the cases, and thereby treatment depends upon the presentation. If the child presents with milder sort of disease, you can have only ACE inhibitor or ARB. Control BP, control hypertension, control proteinuria, and take care of the other things. When there is crescents, you naturally go for a little bit aggressive immunosuppression, like with the IV methylprednisolone 3 to 6 pulses, followed by oral prednisolone in tapering manner. If patient doesn't go into remission, you should try the IV cyclophosphamide, followed by IV cyclophosphamide usually 3 to 6 pulses at monthly. And if patient doesn't go into remission, you can add MMF or azathioprine. Usually these two drugs, either of these two drugs, are maintenance immunosuppression along with low dose prednisolone, maybe in the alternate day. Initially it may be daily. So CNI is kept in more severe sort of presentations like nephrotic presentation, you're with FHS histology. So then your GFR reduction less than 30 ml per square meter per 1.73 meter square per minute for virtually very aggressive disease, very advanced disease. In those cases, perhaps the immunosuppression has no benefit, especially when there is plenty of fibrosis and little inflammatory tissue in the biopsy. You go for conservative management with the RASI and other supportive cares. So what is the guideline like? Currently people are thinking there is a recommendations of enteric-coated budesonide, FDA approved it, and sparsentan, the dual your endothelial blockers, and ARB. So they are the two drugs commonly used. So currently people have guided sort of the immunosuppressive, the IgA nephritis treatment. So I shall only mild presentation, isolated microhematuria, MAST present 0. You give nothing, just watchful observation. A little bit of more advanced, you have proteinuria along with it. You give RASI, ACE inhibitor, or ARB. When you have more advanced disease, nephrotic presentation, you have MAST1 in M1 in histology, you give the prednisolone 3 to 6 months and taper of 0.5, 0.2 in standard way until disease is in quiescent and in remission. Nephrotic presentation with GFR reduction more than 60 ml per minute per 1.73 meter square, M1, E1 and T1, T2 disease, you've been more a little bit aggressive in terms of immunosuppression. You have oral prednisolone 2 milligram, 1.2 milligram, then tapered to 1 milligram, 0.5, and ultimately tapered to 0.25 and quit when the disease is under control. And you also can have over here, you need to have it, the cyclophosphamide 2 milligram orally per kg per day for 3 months or so. In FHGS cases, nephrotic presentation, you have good choice as CNI. Though CNI has the renal nephrotoxic drug, but it is useful over here. But when the disease has progressed to the higher extent, the GFR less than 30 ml per minute per 1.73 meter square, perhaps one should not prescribe CNI, Tacro, Cyclo, and the current Voclo. ANS, acute nephritic presentation, use with mesenchymal endothelial and the proliferative GN. You give prednisolone and MMF, taper, and then continue MMF azathioprine for 2 years or so. RPGN presentation, you be more aggressive with the IP methylprednisolone, followed oral prednisolone, alternate day prednisolone, and cyclophosphamide 6 doses, MPA, and methylprednisolone, azathioprine. Finally, advanced disease, GFR less than 30, as I said earlier, you go for the withdraw the immunosuppression and go for the conservatively managed cases. And finally, in the FACS, plasmapheresis is useful in the hemodialysis dependent cases. And finally, patients, very little amount of patients, ending into your ultimately a good amount of patients that do and worst possible cases as CKD, they are to be transplanted.